Hello, good morning, good afternoon, good evening to all of our participants. Thank you very much for being part of this webinar. We are very happy to have it organized. Thank you very much to all our team that is making it possible, and welcome to all. I would like to give the floor to the Counselor Permanent Mission of Japan to the United Nations, Yoku Sekita, to give us some welcome remarks, please.
Thank you very much, Ms. Gabrielle Dubes. My name is Yosuke Kita at the Japanese Mission in New York. Excellencies, distinguished guests, ladies and gentlemen, I would first like to express my appreciation to the members of the group of friends of UHC and Global Health, and today's speakers, and our partners, including UHC 2030 co-chairs, Ms. Gabrielle Dubes, UNDESA, WHO, and UHC 2030 for attending these meetings. At the 2019 high-level meeting on universal health coverage, world leaders reaffirmed their commitment to achieve UHC by 2030. But the unprecedented human security crisis caused by COVID-19 has highlighted not only the importance of fair distribution of vaccine, but also the importance of strengthening health systems through achieving UHC. And we have observed that the funding gap to achieve UHC is getting worse. In order to fill it, we need to present the current situation to the stakeholders. And for this purpose, it is very important for us to have an objective assessment of the current status and progress of UHC achievement in each country by an appropriate index. So voluntary national review is a very important opportunity for countries to thoroughly review our progress, challenges, and remaining gaps in achieving UHC. The current situation is that not enough countries have used the UHC service coverage indicators and or the UHC financial protection indicators to review their progress on SDGs indicators. Today, I hope that all of you in charge of each country will enjoy the workshop and gain a lot from this workshop. Thank you very much.
Thank you so much for your welcome remarks. I am Gabriela Cuevas. I am the co-chair of the steering committee of UHC 2030, and I would like to give you a very short briefing about our workshop. Universal health coverage is an urgent priority to end the current global health crisis and build a safer, healthier future. At the 2019 high-level meeting in New York at the UN, well, it was a very important moment because we had this high-level meeting on UHC, where the world leaders recommitted to achieving UHC by 2030. UHC 2030 is a multi-stakeholder platform that brings together diverse voices and perspectives for the common goal of achieving UHC, sustains momentum around the universal health coverage commitments, and promotes collective action. UHC 2030 supported PGA and co-facilitators to prepare the UN high-level meeting at that year in 2019 with our multi-stakeholder partners and initiated the stage of UHC commitment to curate diverse views of a range of stakeholders on the current situation and commitments to progress towards UHC by 2030. The first review was published in December 2020, just a few months ago. VNRs present an opportunity for countries to conduct a throughout review of their progress, challenges, and remaining gaps toward achieving UHC. Since 2019, UHC 2030 has encouraging all stakeholders involved in the voluntary national reviews to ensure objective and accurate reporting of progress towards UHC. This workshop's main objective is to increase awareness of global and national measurable UHC targets and encourage the use of the VNR's platform for country accountability to commitments made in the UN high-level meeting on UHC in 2019. In today's workshop, various partners of UHC 2030 will share tools and resources, as well as best practices among countries to review the country progress of SDG number 3 in the VNR process. We hope this workshop and our resources will help you to prepare the VNR report this year. Now I would like to give the floor to Irina Subsevic, Chief of Service from DISA. You have the floor, please.
Thank you very much, and good morning, good afternoon, good evening, everybody, wherever you are in the world. First of all, thank you very much for this opportunity and this invitation to share with you some highlights of the VNR process that DESA has been supported since inception 2016. I'm trying to, okay, I'll share my screen. And with the PowerPoint, just give me one moment, please. Okay. Do you see my screen? Can you see the PowerPoint?
I see it.
Okay, fine. So just very quickly, due to the time shortage, I'll just skim over some slides, but you will have the PowerPoint presentation and then you can look at it in more detail. So these are just to remind us what are the principles guiding the voluntary national reviews. You will see that, of course, they are voluntary. They are country-driven, and they show the progress of national, subnational levels of the implementation of the 2030 agenda. And also they are platform for partnership and present a learning experience. And of course, they have to be in accordance with national circumstances, policies, and priorities. So this is from the 2030 agenda on the VNRs. Here are just some numbers to show you where we are. So as I said, the VNR started in 2016, and you will see according to the regions that the majority of countries have already conducted their at least one VNR. And you will see the Eastern European group, all of these countries conducted at least one VNR. Then you will see now a tendency, which is going to be more and more, the orange column will rise for sure, and the gray one as well, where countries are presenting for more than one time. So you see already this trend that, and this year and this year, as you will see, there are more second and third timers. You see there are 25 second timers and 10 third timers than in previous years. So there are only 9 first timers. So this is a trend that will definitely continue. I just wanted to show you the number of SDGs addressed in 2020 VNRs. In the concept note for this workshop, the WHO did a very nice research on how universal health coverage is covered in the VNRs. So I'm doing it just in a little bit more detail here, in a more, not detail again, on the contrary, more generally on how the SDGs are covered. So you see that the majority of countries covered all the SDGs, and there were 47 countries that presented, but 2 did not submit the reports. So out of 45 reports, you see that 28 addressed all goals, 11 addressed majority of goals, 5 addressed some goals, and 1 country did not address any goals. So, so you can see that a majority are already reporting on the goals. Now, going to the why undertake VNR and why VNR can be beneficial to a country. You can see here some of the of the experiences that we have gathered through all these years. VNR is important because it changed mindsets, which means that you really need to have a different type of the engagement and different type of actions to implement the 2030 agenda. And of course, it should have the whole of government and whole of society approach. It also proposes to have a stock taking and a coordination integration values for the country so that they can coordinate better for the implementation. And what is also important is to say that the VNR is not a report, it's really a process. And that's why it's worth to undertake a VNR. Now, it also shows we have asked countries to show in their VNRs, especially this year, but you will see also some of the lessons, some of the measures already shown in the 2020 VNRs to recovery from COVID. It's also about the support, so you can identify and communicate areas in which country needs support. It's also area for partnerships. It's above all accountability tool to their citizens and the communication tool. And it also, what is very important is to follow up the VNR. So it's not something that you have done once and then you forget about it. So here I have specifically focused on the health measures that the 2020 VNR countries have reported to. So you can see here that what they are talking about is healthcare free of charge, building resilience of public health systems, establishing testing and quarantine centers and sanitary cordons, undertaking isolation and tracing, digitalization, updating medical equipment, increasing remuneration for medical personnel, promoting private sector participation in healthcare and e-health services. Now coming to the SDG's voluntary common reporting guidelines, we updated them as recently as February 2021. And one of the most important reasons why we did it was to link the COVID-19 recovery plans with the 2030 agenda and the concrete measures and accelerated actions that they can do it, and also going beyond assessing negative effects of COVID-19, also being analytical and forward-looking, and show what can be done in the future also for some future pandemics. And then lastly, what could be improved? Of course, you have also that in your concept note that VNR is an accountability tool. So it would be good to show an honest picture of progress, but also about gaps and challenges, identify the support is needed, where support is needed, and use the SG voluntary common reporting guidelines so to increase the comparability and also to increase the peer learning element of the VNRs. And then lastly, here are just some resources which you can tap into. There are all the links are provided here, and you can use that. I will share this presentation. Thank you very much.
Thank you so much for your kind explanation and the presentation. Now we are moving to the next panelist. We are going to talk about an overview of SDG3, a thematic review process. And I would like to give the floor to Mr. Werner Obermeier, Director, WHO Office at the United Nations.
Thank you very much, Gabriela, and good morning to everybody. I am also going to skip through the slides fairly quickly due to the time constraints, but the package will be distributed to everybody. You see here that there are two main objectives included in the political declaration, which me and my colleague Jessica Clark, who is also participating this morning, had the honor of helping to steer through the General Assembly a couple of years ago. The first deals with the service coverage, the number of people, 1 billion additional, just in a few short years' time, and then obviously that the coverage should not result in catastrophic costs. Next. This mirrors to a large degree the two targets which were included, the indicators by the Statistical Commission, 381, the coverage of essential services, and then 382, the proportion of households that are not suffering from a percentage of catastrophic costs. Next, the service indicators, the tracers that we have to measure these, as you can see, there are 16 of them. They are grouped according to reproductive, maternal, neonatal, and child health. Then the infectious diseases, non-communicable diseases, which just this morning I note has gone up to 65% of the global burden of death due to COVID-19. And then the final category there is the capacity, the health workforce and facilities. Next. This index shows what we have long expected. The service coverage has improved, but you see on the left there that Africa, Southeast Asia, and the Eastern Mediterranean still remain under the world average. And on the right, you see lower middle income countries also under the world average. Next. So the financial protection, as I mentioned earlier, the catastrophic cost for paying for healthcare, there are three thresholds which are used. And you see on the schematic there that we use the 10% and 25% threshold. Greater than 10% being paid for health outcomes already now are more than 100 million people in the world. Greater than 25% obviously is something which put people deep into debt, and they have to sell their assets and their property to pay for health, which is not what should be done. WHO, on the next slide, you see have staff working in 149 country offices. We are the largest field presence of the UN system in the world, and we work with all these countries in order to achieve universal health coverage. The next slide gives a short summary of what we have found in all our surveys done with countries, that there is widespread, almost in all countries, disruption of essential services. Whether it's partial or fully, all services have been affected. We see a lot of increase in TB cases. These are the communicable diseases, obviously. We see a lot of cases increasing in terms of hypertension for non-communicable, and you also see maternal and child health and nutrition has been severely affected. Emergency services, understandably, because they have been beefed up to deal with the pandemic, were the least disrupted. But this is, of course, only of temporary nature. And then, which is really worrisome, is that mobile services and campaigns which reach the people in the most vulnerable and far-off areas, and which many countries, developing countries, rely on, have been the most severely affected. The final slide is a compendium of all the resources that are available to you. And you can see there is a massive number of information on each of the targets included in SDG3. And this is for you to look at afterwards. Thank you. I'll conclude there, Gabriela.
Thank you. Thank you very much for your presentation. Now we are moving to the next panelist, who is going to be Akihito Watabe. He's the task lead of UHC 2030 core team, and we're going to talk about the state of UHC commitment review, the country profiles, and all these very interesting documents that I would like to recommend to you. Please, Akihito, you have the floor.
Yes. So good morning, good afternoon, everyone. So I'm from the UHC 2030 Secretariat, and this is a presentation we used in the last November on the VNR Knowledge Sharing Workshop on the presentation of a state of commitment work, but an updated version that we like to explain more details of the country profiles. So last year, it was the first time we started the state of commitment work and also prepare the country profiles. And as part of the review process, we analyzed the previous state of commitments and also the VNR reviews. And we found out that many countries, of course, review the SDG3 and also UHC progress narrative, and also some the data, but also we found out that only 13% of the reports covers UHC index or financial protection index. So we found out this is something we need to help the member states and civil society and other partner to how to report the UHC progress, because the UHC is a new area in the SDG from the MDGs to SDG, And also the indicators are also new. So this is something we need to help the member states to do it. And so that is the first purpose that we prepare the country profiles. So our USC data portal provides a snapshot of the state of USC individual country commitments and also the overall progress of the country on the area of universal coverage, but also more cross-cutting health agenda. And this country profile includes all 193 UN member states, and including the key USC and other SDG3 indicators. Let me show one example of the country profile. And as you can see the video, this country profile includes a political commitment expressed by leaders, measurable US national targets, identify people left behind, trend and state of service coverage, financial risk protection, and equity disaggregation, USC-related policies and legislation, and the trend status of health systems, including health workforce financing, and then also health financing and domestic resource mobilization efforts, multi-stakeholder engagement. And then, of course, the health emergency, including COVID-19 live data, and then you can download the indicators and data sets from our website, the country profile. And these country profiles are available in 193 countries, and that as a baseline last year. And this year we are planning to update the 40-50 VNR country 2021 to make sure that we also reflect the latest review of the SDG progress from countries. And then the next slide is the global progress. This one is just an overview of the global progress in UHC indicators 3.8.1, 2, and also the country that have already passed the UHC registration, and also overview of the VNR progress report on the UHC. And then the last slide is the background data dashboard. You can also see what kind of review have already done by member states. So these are text related to UHC health system extracted from VNR countries. So you could also see what kind of review have done by each country. And that can be the reference from the other member states, how to report the UHC health system progress in the next VNR. And also for the civil society, this is also source information for you that to compare the progress and reports from the previous report from member states, and then to compare the latest one. That is also information for the civil societies and the multi-stakeholder. So hopefully our resources are useful. We have the whole list of the state of USC commitment resources, country profile, USC data portal, and other advocacy and the guide that we have already produced, including the list of commitments in the UHC Higher meeting in 2019. So we are happy to share the list of the resources after the workshop. Thank you very much.
Thank you very much, Akihito. And now we are moving to our next panelist, which is precisely the country consultations, the civil society's plan for country consultations in 2021. The speaker is going to be Kwat Hang-on from CSIM Advisory Group. Please, you have the floor.
Thank you very much, and good evening, good afternoon, good morning this evening here. So it's my pleasure to represent civil society engagement for UHC 2030, to share with you about the country consultation process that we are going to do to organize in order to contribute to the State of UHC Commitment Report. So as you know, as mentioned by Mr. Kita, the co-chair of the group of friends, there are not enough country reporting on UHC indicator. And Dr. Akihito just mentioned that as well. But on the one hand, there's not enough country reporting on UHC indicator, but on the other hand, even when the country do report on UHC indicator, it often not fulfill the principle, the guiding principle of SDG, which is leave no one behind, reach the furthest behind first, because it's often when we focus on the number, we may not have the full number, because there are people, the group of people may be invisible, not included in the denominator in the data at the beginning, for the beginning, such as the undocumented people. So they are not counted. So when we only focus on the number, we may forget people. But also when we only focus on the number, we have a tendency of reaching the low-hanging fruits first, is to go to the easier to reach segment of the population and not the one who needs the most, because the one who needs the most are usually the one who are harder to reach. So on the one hand, we need the number, but on the other hand, the number is not enough. We need to be able to identify the people who are left behind, who are currently left behind. And I think that is the country consultation we are going to organize. It is to complement the VNR indicator for USC to really hold the principle of leave no one behind and reach the furthest behind first. And as Mr. Zusevic from DESA mentioned, VNR should be a platform for partnership, and this consultation is fully in that spirit. We want the community and civil society become a partner for this VNR. So the topic that we will focus on the country consultation, there will be some of the topic as the following. First is, which population are most left behind? So in the country, in each country, the population that left behind can be very different. So as you can see in the slide that Dr. Akihito presented for the country profile, there's a box that that said the populations that left behind. So if we have this country consultation, we may be able to identify which population that are currently left behind, so that the country can make the effort to reach them, to not leave them behind. And to further that question, we will also discuss what are some of the challenges that these people face in assessing quality health services. And the other aspect of the coverage is the health problems. What are the health problems that currently being left behind? Is it some infectious problem or non-communicable disease or prevention, etc.? What are some of the critical UHC gap in the country that the indicator may not speak the full picture? And then finally, what's also very important is that what can government do to close the gap and strengthen health system so that the UHC and the health system are more inclusive and equitable? So we will organize that in the form of a group discussion that people feel safe and open to discuss. Included in this consultation will be community representative, the youth, the young people, the CSO and UHC advocate, and the researcher, the people who do research on UHC. We are doing this in collaboration with a range of country and regional and global partner, with UNAIDS, with International Federation of Red Cross and Red Crescent, the regional platform on community rights and gender of the Global Fund, the NCD Alliance, Global Health Council, People Health Movement, Save the Children, and a number of other partners. So we are selecting the country at the moment, the country in the VNR. We are working with the partner to come up with a good list of country represent all the region, different region. But we also try to get this process happen in as many countries as possible, so that we can create a movement in the country on USC to support this process. And we plan to organize the consultation in May and June, so that we can contribute to the State of USC Commitment Report on time. But first and foremost, it's not just only about the State of USC Commitment Report. It's about engagement. It's about the spirit of partnership. So we really hope that in each country, when there's a country consultation happen, there be an engagement from the government, the state as well, so that we all learn from our people, so that no one is left behind in USC. So thank you very much.
Thank you. Thank you very much for bringing the perspective of civil society, which is also very important, and governments must never forget that. Now we are going to give the floor to the local and regional governments. We're going to have Ana Calvete to explain the UCLG's upcoming report to the 2021 High-Level Political Forum. Ana, you have the floor. And well, just a very small announcement. Please, if you want to have any participation on the country's perspective, please raise your hands. We would like to have a very organized intervention, because we don't have a lot of time, but please start raising your hands. Ana, now you have the floor.
Thank you. Let me share my screen. There we go. So thanks for the invitation. As Gabriela said, my name is Ana Calvete, and I work at the Research or Gold Department at UCLG. UCLG is the largest world organization of local and regional governments. We represent the values and interests of over 250,000 local governments and their associations from 140 countries vis-a-vis their national governments and international community with whom we actively engage. In terms of universal health coverage, we have a fruitful relationship with the UHC 2030 movement. Our Secretary General is a political advisor, and we're in the process of becoming a member. We defend universal access to public healthcare beyond the provision of healthcare services. And well, it is globally acknowledged that local governments have been at the front line of contenting and recovering from COVID-19, caring for their communities, and providing basic services such as health. And they are core actors in achieving the SDGs, which is kind of why we are here today. UCLG develops a yearly report to the HLPF on SDG localization based on survey responses and desk research from local governments, networks, experts, and an extensive analysis of VNRs. The report analyzes the evolution towards the localization of the SDGs in cities and territories around the world. In 2020, in the last edition, we concluded that more and more national governments are involving their local peers in the VNR processes, from 23% in 2016 to 55% last year. However, despite this is very encouraging, regular consultation of local governments in the national coordination mechanisms has alarmingly been acknowledged only in 31% of the reporting countries, which often leads to VNRs failing to provide a comprehensive view of the local realities, also in terms of health and care. So, as we all know, this crisis triggered by COVID-19 has not only turned the health and care systems upside down, but affected the provision of services and functioning of the institutions at all levels. For this reason, this year's report will pay particular attention to the impact of COVID-19 on the SDGs and the measures undertaken by local and regional governments to face it and initiate recovery. SDG3 will become central, as you can see on the screen, and will be analyzed through the Health in All Policies approach. Based on this approach, we will analyze, for example, local initiatives for social inclusion and protection of vulnerable groups, which has saved lives, basically, tactical urbanism, which places sustainable mobility, air quality, and health at the core of development, and strategies for just and green recovery led by city networks such as C40 and eClay. And we will see how all of these, arranged around the 5 pillars of sustainable development, have had an impact on the health and well-being of the populations, and also vice versa, how decisions around health have affected other policies, building on this cross-sectoral and interrelated nature of the whole 2030 agenda. So as said, local governments as the level of government closest to the population with capacity to leave no one behind, to link this presentation to the previous one, they have been key in the fight against poverty and inequalities during the pandemic by providing access to basic services, amongst others. But it is also essential to analyze these actions along with the role of national governments and frameworks, competences, financing mechanisms, etc. So in this regard, for us, it will be key to assess to what extent local governments have been involved in the design and implementation of national recovery packages. So other tools that we invite national governments to use for their VNRs, not just to report, but to inform better policy making are, for example, VLRs. VLRs, as you know, are a commitment in favor of the SDGs, a political tool that can enhance transparency and trust, reporting on local progress and challenges, and bringing the local voice to the international arena. They're currently extremely diverse and growing. Last year we had 37. This year we already have 64. Plus 20 which are underway, and other subnational reports such as 15 VSRs, voluntary subnational reviews, which are led by local government associations, are also arising. And also, which is important, is that national governments have started to see in them a natural ally and start to find synergies with these mechanisms. You can see it on the screen. VLRs such as ESPOD and Bristol's can complement the nationally collected information with evidence from the ground in the localization of the SDG3 and other SDGs, and other experiences, although they may not be shaped as VLRs, offer localized indicator systems such as the Barcelona Metropolis one that you can see also on the screen. At UCLG, along with key partners such as UNDP and UN Habitat, we developed hands-on tools such as the guidelines for enhancing the relationship between VNRs and VLRs, which is about to be published, and I will be very happy to develop further if need be. So to summarize, it is for us indispensable that national governments count on local and regional governments in their progress towards universal health care, and developing an enabling environment for these to execute their mandate towards SDG3 is essential. One way being, for example, ensuring integration between VNRs, VLRs, and VSRs. So thanks for listening. And of course, for any questions, comments, or requests, feel free to reach us through any of the means that you can see on the screen. And we invite you to take a look at our reports and tools that you can find on our website, and I will send the link straight away. And of course, we encourage you very much to reach out to local governments in your territories. Thank you.
Thank you very much, Anna, for your remarks. And yes, we all know that we need to consider always local governments as a key example for implementation. Now we are going to move to the national examples. And I would like to give the floor to the permanent mission of Morocco to the United Nations, please.
Good morning, colleagues, and good morning, Gabriela. It's a pleasure to meet you virtually, all of you. I'm sorry, I'm assuming it's a morning, but I'm aware that it could be an evening or an afternoon. So thank you all, and it's a pleasure to see a lot of faces. My good and established friend, Dr. Warner. Hi. So for Morocco, as you have introduced, it's our pleasure to take part in this event, especially that we have actually presented our second VNR on 2020. So Morocco overall is on track with its promises, and it's also its work on the implementations of the SDG agenda overall. But as indicated by His Majesty, the area of health in particular and education is we would say it's a finality for the implementation of the SDGs. So I think it goes without saying that once we really target and get achieved all the goal in its globality with its targets, we could just hope for really good health for our citizens and the entire global community. And I think what happened now with the hitting of the pandemic, it just showed us the severity of what happens if we don't take care of the health sector overall. I know that my time is short and I've been asked to cover in particular target 381 and 382, so I will not prolong the introduction part, though the overall I would say the strategy that has been conducted by Morocco on the health sector itself started before the launching of the SDGs. So actually we had a national sustainable plan starting in 2000. So I think that what helped Morocco in achieving this level of progress in the implementation, because we, in a particular or a technical reason, we have started way before, and also when my Minister of Health and Minister of Foreign Affairs attended the UHC high-level meeting in 2019, we have hosted a side event concerning 382 target, especially financial aspects with the African continent. So the political leadership also helps when with the, as we always say, when we are negotiating declarations or also negotiating a resolution, we always invite the high level, because we know that when we bring our leaders to New York, it just gives a momentum to national policies back home. So I'll briefly talk about what happened with 381 service coverage. So all over on the VNR that we received, and also the inputs that I received from my Ministry of Health, it's without surprise that the pandemic has hit us as it has done for states all over the world. But we're glad that we are still doing well, especially now I'll talk about the service coverage for the three particular area. First, the maternal and the child health. So maternal mortality rates fall actually by 112 in 2010 to 72.6 in 2018. So the progress has marked especially rural areas. And respectively, now we have a really a low rate of deaths in rural areas, and we believe that the decline has happened due to the development of health services offered to women, in particular in public hospitals, and also childbirth related services offered at public hospitals. This proportion decline of maternal and child mortality was attended because also the Ministry of Health has recruited more skilled personnel to help in this process. And with that, I'll move to the second segment, which is also the control of communicable diseases. So Morocco has implemented a wide strategy response to transmissible diseases, including HIV/AIDS, tuberculosis, and malaria. So in terms of HIV, the latest estimate we have says that the number of new HIV infections actually remains very low in the population, with an overall estimate of 0.03 per 1,000 HIV negative people in 2019. So we are glad it remains very low. Concerning tuberculosis, the annual incidence in all forms has fallen between 2015 and 18 from 101 to 99 cases in per 100,000 inhabitants. And the National Tuberculosis Strategic Plan of 2018-21 also has helped in putting a reduce to this problem overall, and managed to reduce it by an average of 40, and hope to reduce it by an average of 40% by 2021. And we're glad that even the numbers of deaths linked to this disease have really been reduced. For malaria, Morocco hasn't detected since 2005 any indigenous case in Morocco, and actually WHO has declared Morocco as tuberculosis-free back then. The third item concerning non-communicable diseases, and for Morocco, with the non-communicable diseases, we have added even mental health and trauma reduction, on whatever they call it, the appellation in French. So this whole aspect also is taken care of, and we're having a national strategy, especially for cancer, and it's also under the royal initiative. We have built centers for taking care of people with cancer, especially women with breast cancers in rural areas and all over the nation. So according to the ministry, this particular I would say cluster of diseases, non-communicable diseases, is a bit hard to really. We're aspiring to do better, but because of the epidemiological transition, it's hard. And now also with COVID, I would say repercussion and health, especially on its cardiovascular and respiratory chronic diseases. So it's not helping that much. So in this area, a lot of work has to be done. And I think I received a lot of also inputs about the national strategy to achieve UHC overall, whether in the prevention or treatment of substance abuse, or the global road safety, also access to sexual and reproductive health care services. So we have national strategies for each one of these, but I think I covered the first target, and now I'll move to target 382, which is basically focused on the financial protection. So for Morocco, we, as I said and I indicated before, we have started this the UHC without its formal appellation back in 2000. So Morocco actually adopted in 2002 what we call Basic Medical Coverage Code. And it was revolutionary back then, because it obliged the ministry and the government to ensure that every Moroccan has to be covered, whether he is or she is employed or not. And with that, it got extended. So in 2005, we came up with what we said compulsory health insurance component. And this one was targeted for economically disadvantaged Moroccans, especially in rural areas, and also those in the informal sector. And then, given all the successes we were seeing in health-related achievement, we came up on 2015 with another coverage that was targeting or extended to students who weren't covered by a medical insurance before. So all students are starting because according to Morocco law, so before 18, they are covered by their parents' insurance. After that, now they have their own, so that they get the full coverage. So we have extended and almost 250,000 students in college are being registered and are covered by this. And I think I'll conclude here. I know that I don't have much time to discuss, but I will be very happy to answer questions in a Q&A session. And I'd like to sum up that we were doing great and we were hoping for the best, but the pandemic, according to the statistics we received from the ministry, has caused a potential overall loss of almost 9 points in economic growth in the second quarter of 2020. So it's sad because it's gonna affect all the revenues for the health sector. But this is a hope for, I think, all member states attending this event, or even those who are not here, that we could rebuild back better and we could all achieve the implementation. And just a quick note, based on even the target of financial coverage, actually when the pandemic hit, there was a royal initiative that all vaccine, or even before, when we had people falling because of the pandemic, they were 100% covered by the states, and all the charges were free for their accompaniment throughout their healing process. And now also the vaccinations is free for all Moroccan nationals, and also for people residing in Morocco who are not Moroccans. So this is part of, I would say, UHC vision and globality in Moroccan's health sector. I'll stop here, and thank you so much for this invitation, and look forward to the questions. Thank you.
Thank you. Thank you very much for your explanation and all the information about Morocco's improvements. Now, we would like to give the floor to the Development Affairs Division from the Ministry of Foreign Affairs in Thailand. And I would like to remind you all that please keep your participation from 3 to 5 minutes, because we would like to have some time for the Q&A. Thailand, you have the floor, please.
Okay, thank you. Thailand is one of the countries that continue to report the progress of our UHC in the voluntary national review. The government attaches the utmost importance to ensuring healthy life and promoting the well-being for all. We believe that by ensuring access to basic, affordable, and quality healthcare services, people become more resilient and able to contribute more efficiently to the society. For this reason, the Thai government has implemented the National Health Security Act since 2002 to ensure the UHC for all the Thai citizens, and enable all Thai citizens to access health services without concern over cost. The monitoring and evaluation mechanisms for the national UHC progress has also been introduced through several data sources, including national surveys, health facilities and administrative data, medical researchers. Thailand consider UHC as a central pillar for SDG health-related target. Progress of both indicators in target 3.8, namely coverage essential health services and proportions of population with large household expenditures on health, were also reviewed in our first VNR submissions in 2017. The two indicators were also cited in the unofficial VNRs, which Thailand continues to develop on an annual basis to raise awareness and advance SDG implementation at the local and national levels. For Thailand, the implementations of UHC over the past 2 decades has benefited the overall progress on SDG3 and its targets, including an increase in life expectancies, a decline in infant deaths, as well as a decline in malaria and HIV incidents. Currently, the UHC scheme has coverage of 99.85% of the total Thai population. It assisted in reducing household medical expenditure from average of 3.5% of household income in the period before the establishment of this scheme to less than 1.5% at present. The benefits of the scheme have also been extended to cover high-cost services, such as renal replacement therapy, cancer therapy, and stem cell transplants, so that Thailand's USC Coverage Service Index is the highest among the Southeast Asian countries. As Thailand will be presenting our second official VNR at the HLPF this July, the aforementioned progress will be highlighted, as well as the remaining challenges since the first submissions in 2017. The second official VNR will also shed light on how the universal health coverage has contributed to Thailand's effective response in addressing the impact of the COVID-19 pandemic. The scheme allows Thai people to access COVID-related health services for free when access to healthcare services become even more relevant. Last but not least, the second official submissions of the VNR also leverages data gathered through Line Ministry, consultations with stakeholders, as well as through the village health volunteer. Thailand has over 1 million of these ordinary citizens to monitor COVID cases, provide care at the community level, and gather data. Thailand is pleased to see UHC being promoted in various international fora. As a member of Foreign Policies and Global Health Initiative, Thailand has long underscored the necessities of foreign policies and global health to address the issues of international health crisis. We hope that our second VNR presentation will be another opportunity to raise awareness on universal health coverage. We look forward to continue to working closely with all countries and stakeholders to advance UHC and sustainable development goals as a whole. Thank you.
Thank you. Thank you very much for your intervention. Now I would like to give the floor to our last speaker from the National Examples, which is the representative, the third committee, the permanent mission of the Republic of Kenya to the United Nations. Please, you have the floor.
Thank you, Gabriela. And dear participants, good morning and good afternoon. It's a pleasure to have you in this forum and also to see some familiar faces. From the outset, I would like to thank the World Health Organization, UNDESA, and a group of friends on UHC and Global Health for convening this workshop. In line with UHC 30 targets and commitments, at the heart of Kenya's 2030 agenda is mainstreaming the SDGs at both the national and subnational development frameworks through a consultative and interactive process with various stakeholders. Under Kenya's Big Four agenda, which consists of carefully selected sectors that are expected to have the greatest multiplier effect in the economy and overall well-being, Kenya has prioritized universal health coverage for all its citizens. Having previously reported on VNR in 2017, Kenya presented its second VNR at the HLPF in July 2020. The diverse group drafting the 2020 VNR leveraged on the individual sector experience of stakeholders to speak to progress towards the implementation of the 2030 agenda, and I will speak on all clusters urgently. As part of the internal review for the second VNR reporting, policy gap analysis for the implementation of SDGs was undertaken in 2018 to assess the country's preparedness to implement the 2030 agenda. The study found that the Constitution of Kenya, the Midterm Plan 3, and priorities of the government under the Big Four agenda adequately covered the 2030 targets. The study recommended the enhancement of the national policy framework, the needs to review existing frameworks, and the development of new policies to further the 2030 agenda. The 2020 VNR covers progress made in the creation of the enabling environment for the SDGs implementation, as well as progress on all 17 goals since our first VNR report in 2017. Reporting on all the 17 SDGs has provided an important opportunity to assess the progress made since then and identify challenges and present best practices to the international community. Kenya's mission for accessible, affordable, equality healthcare has been a central theme long before the COVID-19 pandemic. This is evident in our policies and legislation. To bring the promise of better healthcare services to life, Kenya prioritized UHC in its national vision and the Kenya Policy 2030 and the Big Four agenda. Kenya began the UHC journey with pilot phase in 4 countries. This pilot phase saw the waiver of user fees on lower level facilities, then introduced several government-sponsored insurance programs for the elderly, vulnerable children, people living with severe disability, pregnant women, secondary school learners, among others. This eased access to health services for millions of people. The government has since added more than 200 community health units with 7,700 community health volunteers and over 700 health workers who have been recruited. Kenya is still in the process of implementing universal health coverage at all levels of care. Going forward, we plan to continue to strengthen decentralization of healthcare for high-level facilities to the community level, to promptly detect diseases of public health concern and provide adequate referral mechanisms for prompt treatment and care. Fortunately, the UHC pilot phase was a success story. It led to an increase in the utilization of health services with over 1.6 million additional hospital units visits made during the 12-month period of the pilot phase. To address the harsh impact of the COVID-19 pandemic on our healthcare system, Kenya instituted a program of rapid capacity enhancement. Health facilities were expanded with increased isolation facilities, testing capacity ICU beds, and provision of oxygen. The private sector also played a role and continues to complement the universal health coverage agenda through an MTIBA, which is a partnership between the government and a mobile provider, Safaricom, and CarePay. This provides e-wallet payment solutions that enable users to save towards healthcare expenses. The initiative has benefited over 4.6 billion users and approved over 1,600 health facilities countrywide. And it has paid over 600 billion during the period under review. Kenya reiterates its call for solidarity and cooperation in assisting developing states to increase investment in public health surveillance systems, emergency response mechanisms, and in resilient health systems. This will ensure that we are all on track to achieving the 2030 agenda. Equally important, countries need to remove barriers to access the diagnosis and care for those who need it, while also addressing the cost of the treatment and ensuring equitable access to healthcare in the true spirit envisioned by the goal of UHC. I thank you for this opportunity.
Thank you. Thank you very much for your remarks. And now it's time to move to the Q&A. We have received one request. Let me find it. So sorry, but technology is not always nice with me. Wait a second, please. We have Dr. Elia Baggio Muhindo to speak from the floor, please. She's from a civil society organization. So you have the floor, please.
Thank you, Gabriela, for the floor. I'm from DRC, Democratic Republic of Congo, COSAMED, Advice for Health and Medicine Academy, COSAMED Santé. Now, I would like to share with you experiences from DRC. In DRC in 2020, it was being organized the conference of universal health coverage, and in which we benefited the participation of Dr. Tedros, the DG of World Health Organization. Also, in DRC, we have a national plan for universal health coverage. And as all of you, you know that the DRC is a continent country. The policy of universal health coverage was decentralized. Was being decentralized. Donc, it means there is a decentralization of this policy in other provinces. It means each province of the DRC has its way bill of universal health coverage. Another thing which I would like to share with you is that in COSAMED, we saw that there is 3 levels of responsibility to universal health coverage. The first level of responsibility is the government. The second one is about non-government actors. And the third one are now health system partners. For that, we discovered in DRC that only 5% of population are covered with the insurance, which is voluntary and or formal insurance. Now, it was being talked that we must pass from the voluntary insurance from formal to informal. It means to the obligatory insurance. Things which is not easy, but it is known that we have a great work to do so that we may achieve this promise of UHC. Thank you for the mic, and over to you, Gabriel.
Thank you so much, Doctor, for this conversation. I think that knowing more about the best practices and the national examples is always important to share in these webinars. And well, as we haven't received any more questions, now I would like to give the floor to Eka Kipiani, Counselor of the Permanent Mission of Georgia to the United Nations, for her closing remarks.
Thank you, Gabriela. I would like to thank all speakers for their very interesting presentations. And I think the experiences which has been shared today would be useful for the other member states, and they will use the VNR platform for reporting on the implementation of the declaration on UHC, which is a very important document, and the most important, of course, is the implementation of this declaration itself. And of course, we have to use this platform to also report on its implementation, and thank you very much. Thanks for all participants. Thanks to all participants for their participation, and have a good day.
Thank you very much, and thank you all for your participation, for your sharing. Thank you to the organizers, to our teams, and hope you have a good day, good afternoon, or evening. Thank you very much.
Thank you very much.